Cool, but then let's start.
Great.
Welcome everyone. Welcome Meizi. Very happy to have you tonight here. Federica, also welcome. We don't see you, but we will hear you mostly in French because this session is also translated simultaneously in French. I will try to speak slower, and I think that would be good to make sure that the translation can follow. Tonight we will, or Meizi Eliezer will discuss the topic of hyaluronic acid in dental surgery, and whether this is bringing any value in periodontal and oral surgery. It's going to be a dense session with a lot of new information, clinical and scientific. You will have surely many questions. For that, don't hesitate to use the function at the bottom of your screen. And at the end of the session, we'll try to answer as many questions as possible. This session is recorded. It's also on live streaming on Facebook. And the video will be made available on the Regeneration website, as well as on Peri-Home, I believe. On these words, I propose to introduce you a bit more formally to our audience. So, Dr. Meizi Eliezer is from Israel, but as you can see, a very big international experience. She's, let's say, first a clinician, like many of you, having a private practice, bringing obviously a very good understanding of the clinical reality of treating patients and all the constraints that you have around that. But on top of that, Dr. Eliezer has a scientific approach, a scientific understanding of hyaluronic acid, having studied and done some studies and meta-analysis that are actually extremely important in this field. So we'll have the chance to have you explain some of these amazing results. And as you can see, she has, or she is a reviewer in first-line journals. She's managing her private practice. She's also a consultant for an insurance company, suppose for litigation cases, experience in hospitals before that. And as you can read here, a long experience, long academic qualification. I would just like to point out that some key highlights in your academic qualifications are based in Bern, Zurich, where you worked with Professor Anton Skoulian, obviously very well known in Perio. So we had the chance to have you not too far away from us for a few years. On that, I will leave you the stage virtually and talk to you later. Bye.
Thank you. Thank you very much, Alexander. Thank you very much. And thank you for everybody for coming and give yourself 1 hour, maybe a little bit more. Let's hope I will stay in 1 hour to come and actually hear what I'm doing and how we can perform with hyaluronic acid in our theater. So let me share you. Yeah,
exactly. I'll let you share your screen. Exactly.
Okay, lovely. So now everybody see, right? Everybody can see it. Okay, just. Okay. So the topic of today will be hyaluronic acid in dental surgery. Does it have value for us as a clinician? And what I would like to speak with you about today is not just I'm going to show you before and after pictures, but also to let you know the scientific proof behind what I'm using, this cross-link hyaluronic acid. So I just want to mention that everything I will share with you today, including videos and also some, let's say, articles, you can find it in periohome.com. This is my website. And videos, live surgery that I perform with an explanation what I'm doing and which material I'm using, you can find on YouTube channel called Perio Home. You subscribe there and then you will get a notification every time I'm having a new video on board. So my mission for you today is to give you the biological understanding what is HA. HA by means hyaluronic acid. I will talk to you also about the evidence-based dentistry regarding hyaluronic acid and when do I use cross-link hyaluronic acid. So let's start. So hyaluronic acid, we know we have it, we are using it in periodontology as part of non-surgical and surgical treatment and also supportive periodontal treatment. We're using HA as an adjunctive to collagen membrane and to bone graft in order to facilitate the healing and of course accelerate the bone augmentation, and to use it as part of implantology. I'm using it in peri-implantitis cases. What is hyaluronic acid? What this material is? It's actually a biopolymer glycosamine glycan. It's sugars, mucopolysaccharides that brought together in a long chain. It can be from several thousand of sugar long. So it can be high molecular weight, but it can also be low molecular weight. It's distributed thoroughly in our body in connective tissue, epithelial and neural tissues, and of course everywhere around the body, also in the gums, in the periodontal ligament. Hyaluronic acid synthesized by integral membrane that sits on the extracellular membrane in this area, and the hyaluronic acid chain is going through this integral channel, and it goes out to the extracellular matrix. Now, the body produces high molecular weight, but we have hyaluronidases in our body that's going to cut this hyaluronic acid into lower molecular weight hyaluronic acid. As I said, hyaluronic acid distributes in our body. You can find it in the eyes, in the hair, in the gums, in the skin, in the joints, everywhere, including in the PDL ligaments. And one molecular hyaluronic acid can absorb 400 molecules of water. By mean, this material has the ability to absorb water, which can also help facilitate healing. And during the time, unfortunately, when we getting older, the hyaluronic acid is go and reduce in our body. This is why you can see that we have wrinkles. Part of the wrinkles is because we lose in hyaluronic acid, which absorb molecules. This is why we don't have wrinkles. But when we get in older, less hyaluronic acid by means less absorbing water. And also that means that our healing process is reduced due to the fact that we have less and less HA in our body. Now, what is the function of HA in our body? It creates a protective barrier against microorganisms. This material is also, of course, it can also stop bacteria from growing. It has a role in keratinocyte proliferation. By means it helping the skin to be more firm. It holds together the skin component, collagen and elastin. It has a crucial function in reepithelialization. It reduces scarring. It's providing cushion in the joints, and it keeps the skin plumpness and moisture for hydration. It also helps in wound healing. It acts as a promoter of early inflammation, but it also helps to accelerate the healing if you have high molecular weight of HA. It helps in cell migration. It provides an open hydrate matrix that facilitates cell migration, because this is like it's absorbing the water as well, and it helps all the cells connect together. And it has a free radical scavenging function. This material is quite busy in our body. Now, this material is not new for us. It's first discovered by Professor Meyer in 1934. Meyer and his co-worker work on the vitreous body of the eye, and they discover this material inside these vitreous bodies. And they start to make some experiments on this material. And because of the name, it's called hyaloid, because this is like the hyaloid channel here. So they call it hyaloid plus uronic acid, that there is some uronic acid inside, so they call it hyaluronic acid to the material. How we manufacture HA? Well, we harvested, it's based on, today is based on bacterial fermentation process. This bacterial fermentation process is helping to produce HA, and the HA, in order to make it more, let's say, more stable and to stay longer, then they add cross-linking by using BDDE. This cross-link will make the HA, for us, the clinician, more stable and will help us to perform better in our surgery. Now, there is a lot of HA cross-links, so that means that not every material in the market that has cross-link HA we can use as a dentist. We need to know that this material was gone through some of, let's say, experiments, and went through a very very deep examination in order to use it in our patients. So HA has properties that we all wanted as a dentist. It's antioxidant. It has no antigenicity, by means there is no reaction to the body against it. It can reduce also swelling. It has an anti-inflammatory function, which is very important for us as dentists. It's biocompatible. It has a bacteriostatic effect. It has a viscoelastic property, which helps us that it can get anywhere to the area of our surgery. And it has an hygroscopic nature, by means it absorbs water. Now, it's not a new material, so in the medicine, they used a lot of HA. They use it in the eyes, they use it for the joints, they use, of course, for against wrinkle. They use it for reducing some of the redness, and what is important for us, that it also helps against diabetic foot ulcers. In fact, diabetic foot ulcer is a very problematic situation for patients. It can lead to amputation of the foot. This is why it's very important to treat this kind of wounds. And they discovered that when we add hyaluronic acid to the diabetic foot ulcers, the ulcer is healing faster compared to the fact without anything, or sometimes they actually compare to other materials. Now, in dentistry, let's say for the past 7 years that I'm using this material, we can see more and more application of the cross-link HA for surgery. We already know that this material has been used for the joints, to wash the joints if we have some problem with joint disorders. We use it, applying it on sutures. We use it for recession coverage. We will see it today, and some of the GBR and GTR procedure. Hyaluronic acid can come in few forms. It can come as high molecular weight HA or very low weight of HA. But we need to understand the difference between high HA, high molecular HA, and very low molecular HA, because the difference between those two HA will cause different function in our body. For example, a very low molecular weight HA will cause to inflammation process in our body. This is inflammatory agent in our body. It starts the inflammation process when we have a healing an healing wound, for example, compared to the high molecular weight HA, that this is protect against apoptosis, and this is actually modulate the immune response by means that if the inflammation is very high, then if we are applying high molecular weight HA, this will reduce the high inflammatory process. So this material, what we use in dentistry, what you see here on the upper right, that this is high molecular weight HA and not low. So what HA do in wound healing? It's actually, its properties are highly depend on the chain length. The shorter is the chain length then of the HA, then we have more inflammatory process. So if we have HA in the beginning, that it's low molecular weight, usually in the beginning of the inflammatory process, if we are adding high molecular weight HA, it will accelerate the healing process by means it will help to get a faster healing. The HA, as you can see, a product of inflammation. It's always there during the inflammatory process, but it depends which molecular weight is more present in that process. As you can see in this diagram, that you can see the mucopolysaccharide is reaching out to a peak in the healing process, and then it decreases. Okay, so that is what it do during the healing process. I want to show you here a study, which is a preliminary results of this study. What's HA doing when they are taking bone graft and mix it with high molecular weight HA. So you can see here that they took autogenous bone and with a safe scraper. If this is a scraper that collecting autogenous bone, they mix it with high molecular weight HA and put it in a post-extraction site. And what they have seen that when you're using the material with the autogenous bone, you will see a faster healing inside the post-extraction site. Plus, the patient also said that it's not written here, but they also described that they have less pain by VAS, by visual analog scale. So histologically, from the histologically point of view, it makes the bone heal and regenerate faster, which is a very important fact for us. So my first mission, biological understanding of HA. So HA is not just for wrinkles, okay? It's not just a wrinkle filler. It's used in many fields in general medicine. It's improved wound healing by only high molecular weight, of course. It's improved the wound healing and accelerate healing. And it's a bacteriostatic, which helps us to reduce the bacteria in the healing site. So I want you to remember, low molecular weight HA will cause to increase inflammatory process, while high molecular weight HA will cause to reduce the inflammatory process. So when we apply high molecular weight HA, it will be like a biomodulation for the inflammatory process. The second mission for today is actually an evidence-based dentistry regarding cross-link HA. Now, I've been, as Alexander mentioned, in Bern University. I did my specialization degree in periodontology and implant dentistry over there. And when I started my specialization, Professor Anton Skulian, my mentor, he saw this material and he started to investigate, and we started all to investigate about it. And we did a lot of research since then on this material. We first wanted to know about non-surgical and surgical periodontal treatments with HA, what the PubMed, what the articles says about it. So we did an article about it, which is a systematic review and meta-analysis. And I want to share with you today the results. We have a lot of other studies which I'm going to mention during this presentation. So we took this material and we wanted to see what kind of research there is and what the research said. So this is a systematic review and meta-analysis of only randomized controlled trials that wanted to compare HA in scaling and root planning versus nothing, or HA in surgery, in periodontal surgery versus nothing. And what we have seen that the results of non-surgical treatment showed that when you take HA and you apply it during scaling and root planning, you could see that the periodontal depth is reduced compared to nothing. The clinical attachment level gain is increased compared of nothing. If you add HA, that means the clinical attachment level is higher, and this is good for us. And the bleeding on probing is reduced compared with nothing. So all of these results showed that adding HA is actually benefits the non-surgical treatment. What's happened with the surgical treatment? So if we're doing periodontal regeneration and we want to add HA to it, does HA improve our treatment? So as you can see, the probing depths after 48 weeks showed that when we add HA to the periodontal surgical treatment, the probing depth is reduced more than if you're not adding HA. And also the clinical attachment level gain. It's better if you add hyaluronic acid to your periodontal surgery. And there is also studies that show periodontal depth after 92 weeks. So in that mean that HA during surgical treatment has a beneficial effect. So this meta-analysis has shown for the first time that there is some benefit of using HA as an adjunctive to non-surgical therapy, and application of HA as an adjunctive to periodontal surgery improve the clinical outcomes. We did another study, which this is an in vitro study. The in vitro study, we wanted to see what's happened if we take cells from our mouse tissue, from specifically we want to take fibroblast from the palate and from the gingival fibroblast. And we want to see what is happening to those cells when we are applying on them HA, high molecular weight HA. And we have seen that there is enhancement of the proliferation of and migration and wound healing properties. Why? Because the cells that come in contact with the high molecular weight HA, they are accelerate and they are performing better during the wound healing process. That's important for us in regenerative periodontal surgery, that the cells will accelerate and will proliferate faster. We also saw that there is an enhancement expression of genes that encoding for type 3 collagen and transforming growth factor beta 3. Those two genes are very, very important in order to reduce scars in the wound healing process. And you know what? I see it a lot. Every time I'm applying high molecular weight hyaluronic acid, I can see, actually, I don't see the scars, especially if I'm doing vertical incision. That is helping a lot for me as a dentist and a periodontist to show that there is no scars and the patients are happy. And of course, the referring doctor is very happy that there is no scars on the tissue. The next, so we done meta-analysis and review on the material. Then we went to an in vitro study. Now we would like to jump and do in vivo study on animals. What's happened when we apply HA on collagen membrane? What's happened to the membrane? Is it degrade faster or not? Why we are actually went to this research? Because I done my Master of Science on degradation of collagen membrane in diabetic rats. And we have shown and we have seen that the collagen membrane degrade faster if you are implanted it in diabetic rats. Why it's happened? Because there is a lot of macrophages when on diabetic situation, and those macrophages are degrading faster the collagen membrane. Now we would like to see if there is any material that can help this degradation, to reduce this degradation, because of course that we know that diabetic situation is higher and higher in the world. So we are meeting diabetic patients, and we don't want that the healing process will be jeopardized because of the diabetic situation. So as I said, diabetic patients are increasing in the world. We know that there is a link between diabetic situation to gums disease. Taylor said it in '98, the diabetic patient have 2.6 times more risk to develop periodontitis than non-diabetic patients. And Law in 1993 describe it as periodontal disease is the 6th complication of diabetes. So we know that diabetic patients are more prominent to go through an extraction or periodontal regeneration or periodontal surgery. They're going maybe to lose more teeth than healthy patients. They're going to go through implantology, and maybe they will suffer more for peri-implantitis. They will need more sinus lift. They would need more GBR procedure. Now, all of those procedures their success depend on the wound healing process. If the wound healing process is good, then those procedures going to be successful. Now, the wound healing process depend on the glycemic state. The glycemic state is something very, very problematic in diabetic patients that's not always stable. As you can see, during the wound healing, we have the protoglycans, we have the HAs that help in the cell proliferation and matrix in order to having the healing process. But the obesities or diabetic patients, sorry, somebody is on the door. The diabetic patients have actually it's delay. They are the one that can cause to delay the wound healing process. Also obesity, because the inflammatory process is high on obese patients. So we were thinking, okay, what if the glycemic state will cause to a more inflammatory process and will cause to a higher macrophages to be overstimulated, and the overstimulation of the macrophages will cause to delay wound healing and also will increase even more the inflammation. This will cause even more to delay the wound healing. The increased inflammatory process and the macrophages will cause to the metalloproteinazote, which are the molecule, the enzymes that degrades the collagen membrane, to increase. that will cause to the membrane degradation and to be faster. So we were thinking, what can help us to decrease the inflammatory process? What will help us to decrease the metalloprotein azote? What will help us to decrease the macrophage overstimulated? This will be anti-inflammatory agent. Well, and then we were investigating about this HA material, and we said to ourselves, okay, let's apply this HA on the membrane and see if it can reduce the degradation of the collagen membrane in diabetic situation. Now, this is before we started, we wanted to this is what I wanted you to see. This is the in vitro study that sorry, this is an in vivo study that showed that the HA, the high molecular weight HA, is actually safe for our cell in our body, for the gingival fibroblast and for the palatal fibroblast to occur together with this material, because every material that we use, we need to see how the cell perform before we are actually putting the material into our body. So this material is safe to use. The cells are functioning very well with this material. Now, this is another study that showed that high molecular weight HA decreased the tumor necrosis factor, and this is reduced the inflammatory response. And low molecular weight, as I said in the beginning, actually cause to the tumor necrosis factor to increase by means to increase the inflammatory response. So our material is high molecular weight, cross-link hyaluronic acid, is very safe material and very good material to use during the healing process. Now, this is the membrane. We used pericardial membrane together with cross-link hyaluronic acid. Before we applied this membrane, we had another job to do. There are two materials in let's say in the manufacturer. We can use non-cross-link HA or cross-link HA. How did we know which HA to use the non-cross-link or the cross-link? We didn't know back then. We actually thought that the non-cross-link HA will absorb better on the membrane because it's like a fluid. So the fluid will penetrate better to the membrane. This is what we thought. But actually, when we took the membrane with the non-cross-link HA and we started to check it every day, yeah, and in hours and days, what's happened to the HA material, we saw that with the non-cross-link HA, the material drops in the first 24 hours. That means we saw it on the plate. There is the membrane and then the material was on the side. That means the membrane doesn't hold the non-cross-linked HA. But when we applied the cross-linked HA, we saw something very interesting. We saw that this material is released from the membrane during the first 10 days in a slow release mode. That means that during the process of healing, this material, which will be absorbed by the membrane, and the membrane will release this material during the healing process of the GBR or GTR. It's depends what we're using the membrane for. This is how we knew that cross-link hyaluronic acid, this is what we would like to apply on the membrane. So we dip the membrane with the cross-link hyaluronic acid, and we implanted it in the calvaria of rats. We divided to healthy rats versus diabetic rats. Of course, from each group, we've put membrane with HA and a membrane without HA. Each of the group has 8 participants, 8 rats. And we discovered that after 2 weeks, we examine histologically the membrane, what's happened to the membrane. And we have seen that when we applied the membrane without HA, we could see, you can see here the membrane, this is a brownish material. The membrane is degraded. It seems like it's not like, let's say, like the healthy membrane that's supposed to look like. And we could see a lot of inflammatory process. And you can see here in this diagram that the diabetic rats without the HA, minus that mean without the HA, the membrane thickness was low compared to when we add the HA to the membrane. You can see here the membrane, and you can see here, this is the HA, by the way. It looks like a yellowish material. We could see that this membrane is quite thick. You can see D+, the diabetic rats with hyaluronic acid, the membrane is like healthy rats. So the thickness is quite thick. You could see here in that diagram that if we compare, you can see D+, that means membrane with hyaluronic acid. You can see the thickness of the membrane compared to the D-, which is diabetic, the membrane that was implanted in diabetic rats without HA. You can see how the membrane degrades fast. Here there is a control group, which you can see the thickness of the membrane with the HA, and the control group without the HA as well, the membrane was thick. So in the conclusion, we saw again that the diabetes accelerate the degradation of collagen membrane, and the diabetes also increase the number of macrophages and endothelial cells within the collagen membrane. The new thing that we have seen, that when we emerge the HA prior to membrane implantation, when we take the membrane and dip it in the cross-link hyaluronic acid, and we implant it in uncontrolled diabetic rats, this will slow down collagen membrane degradation. It will reduce the number of macrophages within the membrane, and it will increase collagen content of the membrane. That means better GTR and GBR procedures for us. And here I want to show you that we study and we want to understand, does HA has an effect on the inflammatory cells, on the macrophages? And here we could see that in D-, when we are, this is the membrane, when we are not dipping the membrane in cross-link hyaluronic acid, we can see a lot of macrophages inside the cells. They're responsible for the degradation of the membrane. And if we're comparing it to a D+, which is this group that we implanted it in HA, we can see less macrophages. So we understood that actually when we add the cross-link HA, this is what inhibits the macrophages infiltration and reduce the collagen membrane degradation. So it helped us to keep the membrane more thick. And here you can see in this diagram that if you take the membrane thickness compared to how many cells of macrophages there is in the membrane, we can see that the higher is the cells, the lower is the membrane thickness, versus if the less macrophages, that means the membrane thickness is increased. So HA helps us to reduce the macrophages amount, which helps to increase or keep the membrane more thickness into a higher more time. I want to show you also another research of my colleague, Dr. Anton Friedman. He wanted to see what happened if we take HA and dip it and take also a bone graft, DBBM, and mix it together. What's happened to that? And he showed that there is more bone at 2 months and less remnant of DBBM particles for a stable volume. That means that HA, the cross-linked hyaluronic acid, has empowered the rule of scaffold in GBR and periodontal surgeries. We need this material in order to accelerate also the change of the DBBM to a better bone, to perform a better bone. And another research that I want to share with you, this is a clinical evaluation, a case series, and we evaluate the recession coverage after 6 months evaluation. That I was presented in EuroPerio 2018. This is my colleagues here participate. We took all of our recession coverage procedure that we done during our specialization program, and we add an HA during the recession coverage surgery. And we have seen, and we want to, of course, to evaluate the recession coverage, how much the root was covered, and if there is any adverse effect if we add the HA. And here you can see, this is a recession. We add here HA. This is the tissue that we take. This is a case of Professor Anton Skulian. You could see here what's the HA performing. It's stable, it makes the blood clot stable. And this is the suture. You can see here half a year after how the healing process, of course, there is no recession and the tissue looks very healthy. And we discovered that when we add HA, we actually see a very nice result to our recession coverage. The healing process was very nice and faster. And after 6 months, most of the recession coverage were covered. Most of them were actually covered almost completely. You can see percentage of root coverage it's in more than 90%. And that means that the HA performing quite nicely. And here you can see a nice presentation. You can see the recession, adding an HA material. You can see what we took, the tissue, the graft tissue that we took from the palate, and what the HA is doing to the blood clot, destabilize it, and the sutures, and 6 months after. Another research, which was very important research for us, the clinician, because this research that done by Professor Anton Skulian and Shirakata and was published in 2021, last year, it has shown that when we do recession coverage and we apply an HA, we are see also cementum develop, compare if we don't add cross-link HA. That means that hyaluronic acid, cross-linked hyaluronic acid, has a very important function in creating the supporting tissue, the cementum. The cementum is very important in order for the ligaments of the new tissue that we are implanted to hold the new tissue. But until then, we didn't know if there is a cementum, new cementum developed or not. So here is the conclusion. The present data have for the first time provided histological evidence for periodontal regeneration of gingival recession defects following treatment with clinical attachment flap and HA. And the clinical use for us is, of course, obvious. We want to add to our recession coverage procedure the HA in order to gain also cementum. So cross-linked hyaluronic acid can be used, as we saw, in a lot of our surgical procedure, in GBR, GTR, in periodontal surgery, in recession coverage, as adjunctive to non-surgical and surgical treatment, as part mixing it with bone graft. And I want to show you now, where do I use hyaluronic acid? Where do I actually adding it? So as you can see, the list is very long. I add it everywhere because I can see the fast healing that I get. I'm adding it to GBR and to GTR procedure. I'm adding it to socket preservation together with the bone graft after extraction to reduce pain and to accelerate healing. Infranectomy in order to stabilize the blood clot and reduce scarring. In pericoronitis treatment, peri-implant diseases for re-osteointegration. I'm adding it to guided, as I said, GTR, and I am using it for periodontal regenerative procedure, for soft tissue augmentation, for recession coverage procedure, and I'm adding it also to the donor side when I'm taking soft tissue from the palate. So I want to share with you a few examples. So how do you treat those cases? Here, this case, you could see that there is a discrepancy between the tissue and where the teeth is located. That means there is about 4 millimeters of deficiency of soft tissue. And this patient is going with a prosthesis that actually with a pink material prosthesis, and she's a young one, she's 24, and she had enough from this prosthesis. And I did perform here a soft tissue augmentation. I'm not sure I will have time to show you today that. For recession coverage, you can see here Miller class 3, recessions. You would see, I think, later what I did. In this case, I did also a recession coverage together with xHyA. And what would you do here when you have, let's say, infrabony defect, a very deep one? It's about 12 millimeter deep. And in that case, what would you do? Would you add the bone with xHyA? And I want to show you some of the cases I'm using xHyA. So here you could see that I open vertical incision lines. I put an implant. I made a flap with a bit of extension to the buccal side, and I made the implant and I sutures. And during the suture time, even before and after, I'm adding xHyA in order to reduce scarring in the area, of course, in the aesthetic zone. In recession coverage, I had a patient here, 59 years old, that she had a sensitive for brushing and for coldness, and she asked to do something about it. I did a recession coverage with subepithelial connective tissue graft from the palate, and I add an xHyA to this procedure. As you can see, a full recovery of tooth number 13. I had another patient which had a recession in the front tooth in 21, and she had a black triangle between 21 to 22. She is a supragingival smile. She had an issue with that. She wanted to make a laminate or crown, and her dentist told her, look, the teeth are not aligned. So if I made only on that tooth or here a laminate or a crown, it still will be seen very not natural, especially when you're supragingival smiling. So she came to me. As you can see, I made her a recession coverage with adding xHyA, and you could see here the papilla that was created, and of course the recession that was closed. Here I want to show you a movie about how I'm adding to the socket preservation procedure an xHyA to the bone graft. So this is a patient with a lost tooth, tooth number 17. She had a fistula over there. I use luxator all the time to extract in order to be on the safe side and not to extract bone together with the extraction site. This is the roots. The roots was a bit absorbed. And here I'm showing you there is no root remnants because it seems like there is a short root. So maybe it was broken, but it didn't. It was just a short root. I'm excavating. I'm taking out all the inflammatory tissues. I'm also scaling the tooth next to it to reduce bone remnants, to reduce calculus remnants. Sterile saline solution. I'm putting hyaluronic acid, cross-link, of course, to stabilize the blood clot. I'm taking a collagen clone, and I'm dipping it inside and suturing in a cross suture. This is a nylon sutures. The nylon suture will stay there for a long time, so it will help to keep the cone, the collagen cone inside. I'm washing everything with sterile solution. You can see the X that I perform here, and I'm applying on it the HA. Okay, this is one of socket preservation, one of the procedure. The other procedure I want you to watch on YouTube. This is also on my YouTube channel called Periohome. So pericoronitis is a very well known to us. A lot of patients has a pericoronitis. A lot of the time I'm not actually taking out the tooth. I'm actually want to keep it, especially if the patient has the wisdom tooth above. So here what I did, I scaled. I scaled very good. I want to take all the calculus, and of course I'm scaling also in the tissue next to it, the tooth next to it. It's important to keep everything clean. And here I'm doing actually like a flap, which is taking out also in a V shape the tissue. And here you can see I'm applying the HA into the socket. And I'm suturing the area. The tooth is, I think, like 2 years later now. He's coming for a checkup. Everything is looking great. The tooth is there. He didn't suffer since then from pericoronitis.
Sorry, Meizi, but
Yeah?
I think we don't see the YouTube page. We just see the your PowerPoint.
Oh,
No.
oh, okay. Sorry. Oh, well, thank you for mentioning it. And not everybody see it.
But
okay.
It was very descriptive.
Okay. Okay, I understand. Do you see now what I'm showing?
Yes, we see your slide set. Yeah.
Okay, so if somebody wants to see how the pericoronitis looks like, you can see it on YouTube channel. Let's see if that can be okay. This is a recession coverage using HA. So this you can see here, I'm taking a subepithelial connective tissue graft from the palate. And you could see, I'm seeing that it's actually can be applied on the area with recessions. This is after, is with HA, and try to make it maybe faster. Okay, here I'm applying collagen cone together with HA, and I'm closing it. Here you can see me placing the HA inside the recession tunnel area. And this is just the suturing, how to suture in this kind. And I want to, I see that I'm not on time, so I'm making it faster. So if you want to see the results, you can see it on my webpage, how it looks like. Now, what is the difference between HA to other agents? For example, Emdogen. So HA and Emdogen are performing differently. Why I feel more comfortable to use HA because this material can be used together with blood. And we have all the time in the regeneration procedure, what can we do? We have a lot of the time blood in the area where we treat. So I feel more comfortable when there is a blood, and of course, even when there is without, to use the HA. It gives me more confident that this material will work. If you use Emdogen with blood, the material is not working and not performing. And plus, xHyA can also use around the implant. So of course, Emdogen is not, there is no sense to use it around the implant, but xHyA can be used around the implant, and it will give also its antibacterial effect. Now, why we need to add some adjunctive therapy to our surgical treatment? Because in periodontics, the wound healing in periodontology, usually when we don't add anything and we don't have a regeneration, every root scaling and every open flap and closing flap, we will gain long junctional epithelium or reattachment. Sometimes the healing process, the wound healing process, if, for example, after orthodontic treatment or when we have an accident, it can cause to a root resorption and ankylosis. This is another wound healing in periodontology. And this is, of course, something we don't want for sure. What we do want, what kind of wound healing we do want in periodontology, we would like to have a new attachment or regeneration. What does it mean? It means that we will get a new PDL, a new cementum, and a new bone. This is what we like to gain. And that can be gained when we get the help of a regenerative material like cross-linked hyaluronic acid and like Emdogen. Cross-linked hyaluronic acid, again, the benefit of it, we can use it with blood, and we don't have to be afraid while we're doing this regeneration process. Now I want to share with you a case of an old 83 years old lady. And I wonder, does age influence the rejuvenation of her gums? Because as you can see from the X-ray, from the CBCT, you could see that the bone, we don't have a lot of bone. You can see here the incisive canal. There is not a lot of bone for implantation. You can see the tooth that it's there, the tooth is wobbly and there was a pus formation coming from it. You can see two external resorption from that tooth. The tooth went through a procedure, a regenerative periodontal procedure, which was failing. And she came to me, her dentist came to me because he was concerned about the extraction of this area and of course the losing of tissue, of hard and soft tissues. Now, which kind of material I'm using? I'm using a few materials that it's important for me in order to gain a good results. As you can see, we have a few components. We have the materials, we have the procedure that I'm going to choose, and we have the patient that was willing to participate in this kind of procedure, and she wanted this procedure. She wanted to keep her gums, and although she's 83, she was really concerned about her gums, and this is why she referred to me. And of course, the doctor that supposed to come and do all of this together. Now, I used the Hyadent BG, which is a cross-linked hyaluronic acid. I used the Smart membrane, which is a pericardial collagen membrane. I used allograft material, and I used a PGA suture of Resorba. And you can see here the tissue, and you can see here from where I took also the free gingival graft. And let me show you some of the results. So this is the implantation of the free gingival graft. You can see the sutures here. I applied here xHyA, and you can see 3 weeks after how the tissue looks like. It looks very nice in my eyes. And if I examine the hard tissue, which I add xHyA to the bone graft, you could see how the bone was actually you can see the vertical and horizontal augmentation of the bone. And this helped me to perform for her also an implant. So you could see here the gums that we gain after this procedure. You can see how nicely it formed. It looks thick, it looks healthy. And the implantology, the sequence of what I did, this is extraction with GBR, with xHyA. And 4 months after, you could see I made an implant. There was a nice bone over there. You can see Straumann implant and see it was implanted on this area. My daughter just passed, so using the right materials can help for the rejuvenation of the gums and also hard tissue to form better in not a lot of time. And I want to show you a procedure that I used in peri-implantitis treatment. You can see an implant that lost, but let's say we don't so care about the implant that was lost. We care about the implant that was here, because this loose implant will also influence the implant neighbor, the implant next to it. And here I want to show you, where is the, I can see that, okay, here is, you can see the video that I took, that I'm using also laser to decontaminate the implant area. I decontaminated it, and I'm using a bone graft with HA, closing it with a membrane, sutured it, and let it heal. So this is another procedure that I'm using HA, because the HA will cause to decontamination around the implant, that the adjusted implant that was, his threads was exposed. Now another hyaluronic acid that helps me, what it helps me in my when I'm implanting tissue, it helps to rejuvenate the gums, to heal the gums better. And here you can see a situation, if you want, there is also the movie inside the Perio home at YouTube. A patient came with, you can see holes in the gums and a pus formation from this area. There was a lost implant here, and the gums looks not healthy. The patient will complain of sensitivity and pain in the gums, and she couldn't brush, and her dentist sent her to me. And this thing you can see after I've treated her with GBR, with I took out with explantation, and I did also a GBR around the implants number 12, and you can see the gums that she got. This is a rejuvenation of the gums. So HA helped me a lot in that case. Another help, of course, link hyaluronic acid in recession coverage done yesterday. So you could see she had also a frenulum, a high frenulum, a recession Miller class 3. This is the tissue I took. I dipped the tissue in HA, and I sutured the tissue under and also applied HA on the root. Here I made a little movie for you, how I applied HA on the subepithelial connective tissue graft that I took. This is, it's suture, that means no open wound healing, no open wound. So, and the HA will help me to get a faster result. And here I'm applying it on the, after recession coverage on the area. I did a recession coverage, which helps also to stabilize the blood clot and to reduce scarring in that area. I'm applying it evenly. This is because I left some of that after I used it on the palate and on the root. I have some of it more, so I'm using it all, because I'm using each one carpool of cross-linked hyaluronic acid for one patient. I'm not mixing it. And if I'm continuing, if I'm doing, for example, a crown lengthening, static crown lengthening, then I'm using the cross-linked hyaluronic acid for stabilizing the blood clot after suturing. That was done yesterday also. And last but not least, this is a 93-year-old patient with systemic problem. He needed extraction of 44 and 45 and GBR. So let's see what I did. I took the bone graft together with HA. You can see I applied here HA. I am applying on the membrane as well an HA, because I want less macrophages, especially when the patient is systemic situation. Then I'm suturing the membrane and stabilize it to the area of the graft. And I'm applying HA above it in order to accelerate healing, especially in systemic patients. Now, from this situation, after 4 months, we got 4 implants, Straumann implants are, and this tooth going to be extracted because it has also a problem. So I didn't care about the gap between it, but the bone was perfect, perfect, perfect. So the take-home message for you. So in dentistry field, we always use high molecular weight cross-linked HA. The cross-linked HA can stay for longer time and act as a matrix for cell to grow and proliferate, especially important for wound healing. HA can use as a blood clot stabilizer. It can be mixed with other bone graft in order to create a sticky bone. It can be used in a socket preservation to accelerate the healing and to stabilize the blood clot. It can be used for recession coverage and crown lengthening. It can be used as part of peri-implantitis treatment because it has antibacterial effect. And it can be used at the donor site in free gingival graft or subepithelial connective tissue graft in order to reduce the pain and also to accelerate the healing. And of course, after suture, in order to reduce the option of scars. So hyaluronic acid, the cross-linked hyaluronic acid, for me, it's something that I'm using all the time. So thank you very much for staying until now. And thank you very much for, for coming to hear me. And I hope you have questions. And this is my email and my number. If somebody wants to write me WhatsApp, you're always welcome to write me. I'm answering all the time.
Thank you so much for this very nice presentation, Meizi. This was very visual and very rich in information. We do have some questions, so maybe we can start with the one in the Q&A. Does HA help solving the problem of black triangle after solving crowding of anterior teeth by orthodontic treatment?
Wait, again, the questions, please.
So does HA help solving the problem of black triangle after
orthodontic treatments?
Exactly.
Well, the black triangle is a big problem, and the HA is not it's not a solution for the black triangle. It's part of the solution. That means it's not the only thing you need to use in order to close the black triangle. So we have to examine the patient. We have to understand why that black triangle is caused. Is it caused because there is a bone degradation, and this is why the tissue is going down, or maybe it's because abusing the tissue because of high flossing and overuse of interdental brushes, or calculus, for example, or it's because of not putting the teeth on the right manner. So each one has a different treatment plan that we need to think about. So it's not one solution for everything. If I'm trying to, so it's a very nice question, but my answer, this is not the solution. It's part of a solution. Okay, it's part of the treatment plan.
Good, thank you so much.
Yeah? Okay.
Then here is a question. So in your private practice, how would you say that the fast healing translates into cost saving or generates revenue? Does it help you to save time? Thank you.
Yes, it helps me and the prosthodontist that sent to me the patient to save time, because when you get a very nice bone after 4 months after extraction and bone augmentation, very problematic situation, if you get a good bone after 4 months and you can implant an implant that after 2 months, that for example, Straumann, after 2 months, you can already upload the crown, then for us, we saved a lot of time. And also the patients. About the cost, well, it depends how much you're charging, but it's, for me, in my eyes, it saves a lot of problems in the future, because when the healing is better and when we get a better bone and when we can make everything faster in a good way, not in a bad way, yeah, that the bone is healed good, we have a good bone augmentation, then everything is for the patient is everything is great. Most of my patient doesn't call me the day after and said, oh, I'm having pain, or not even after a week, nothing. When I'm calling them, how do you feel? Everybody feels good. They don't suffer from pain. And I think part of it is due to the fact that crosslink xHyA reduced the pain and reduced the swelling. So for me, I'm quite happy to reduce their suffering.
Good, thank you. Can xHyA be used in periodontal regeneration instead of Emdogen?
Yes, it can, and we have proof for it from Anton Skulian research. It published in 2021. I showed it today, and it showed that it creates cementum. That means there is a regeneration that helps, that the xHyA helps to be to create. So there is a cementum regeneration during recession coverage procedure. When we add xHyA, we have a regeneration of cementum on the root during recession coverage. So
Good.
yes.
Thank you. So when you mix xHyA with graft material, what quantity of xHyA are you using?
Okay, this is you could see on one of my videos in YouTube channel or in my website that when I'm mixing it, I'm adding the material until I see that all my bone graft is covered and mixed with xHyA, and I leave it for about 2 or 3 minutes, and it becomes sticky. And I'm adding it by the eye. There is not depend how much bone, how much cc bone you used. Yeah, so if you're using 0.25, 0.5, 1 gram, it depends. So I'm usually use 0.25 or 0.5, and I'm using it until I see all the bone is stick inside the crosslink hyaluronic acid.
Good, okay, thank you. Then Marta wanted to see your last screen, please.
Last screen, okay, not that one, wait. This one, Marta? I don't know if she's here or not.
While we watch this. So I have another question here. While we look at
Marta respond.
Here, perfect. Yes.
Okay.
So Carla is asking, can a complete growth factor be used together with xHyA?
Wow, that's well, can a complete growth factor, that mean which one? There is a lot of growth factor. You mean something from outside, manufacturing outside, or, well, I don't know which one, so I cannot answer it. So we need to see what the study said specifically on which kind of growth factor.
We do get pretty frequently the question to know whether PRF could be mixed with the xHyA or even Emdogen with xHyA.
Well, until we don't have a study on that, we cannot answer it. And I didn't see any study, and I don't see any logic to mix between xHyA to Emdogen, or to mix between xHyA and maybe PRF, but still I don't have any research about it, so cannot know.
Okay. Question about so the xHyA can be used for closed sinus augmentation mixing with bone graft.
Yes, I do it a lot. I didn't show it here, but I do use it, and actually the sinus looks amazing when I do I do CBCT always before the sinus lift and after the sinus lift, 6 months after the sinus lift, and it looks beautifully. If somebody wants to see it on my Facebook, there are some pictures of the sinus lift after using HA and bone grafts, which there are a mix allograft and xenograft together. And it looks beautiful. After 6 months, I made the implantology, and yeah, it heals very nicely.
Question: what is your technique to improve black triangles conservatively for the aesthetic purpose?
How to prevent it, or how to? What is the...
I think here it's more like a curative approach, but conservative. Do you basically treat black triangle mostly surgically?
Yes.
Or do you also do it?
Mostly surgically.
Okay.
Yeah.
So maybe last question. In perio, when do you use a membrane with HA? Same question with xenograft material. When do you use xenograft? When don't you use it?
Wow. So xenograph, it's very important to understand that xenograph can also cause some of rejection to the tissue. So if we want to reduce it, it's better to dip the membrane in a cross-linked hyaluronic acid because it will stay for longer time and it will accelerate the healing. And I believe that it also will reduce this tissue to reject the xenograft. A lot of the time, I see that the doctors put xenograft. I don't put anything or put membrane that doesn't cover all the xenograft, and then it's degradate faster, and you can see the bone graft sticking out of the tissue, and sometimes causing even like pus formation around it. So I don't use a lot of xenograft, I must say, only when I was in Bern, because there is no allograft in Switzerland. That's correct. Because there is no allograft, but in Israel we use a lot of allograft, and I'm using less xenograft. Nevertheless, if you have only xenograft in your country, then I recommend to mix it with a cross-linked hyaluronic acid in order to make those bone graft to perform and to become as a bone, and don't condense it. So that means don't make it so tied together. Let it a bit with space. And what's beautifully HA doing, it makes spaces between the bone grafts. So that means the blood cells and the vessels can come inside and perform a new bond between the xenograft particles, which of course better for healing.
Okay, thank you so much. I think we've basically gone through all the different relevant questions. Maybe a last one. What would be your gold standard, allograft with HA or autograft with HA?
I usually mix allograft and autograft and HA together. How do I do it? If it's, let's say, if it's an area, for example, after extraction, I do grind a little bit of bone. So, and then I mix it together. Whatever bone I can take, I'm taking, and I'm mixing it together with the allograft and HA. If it's an implant, then when we take the drills out of the implant area, then the drills is with full of bone. So this bone, I'm mixing it together with the bone graft and the HA. And sometimes if I don't need bone graft, I'm just using it, the HA, and put it around. I'm bringing it back after I put the implant. I'm putting this autograft with HA on the area of the implant. I'm bringing it back to the sites that I took. So, and here, by the way, I don't need a membrane. Why? Because this is autogenous bone. It's part of our body, and you don't necessarily need, unless it's a big, of course, big GBR around the implant.
Okay, good. So that was the last question. We will share, as said, the video on the different platforms. Peri-Home, Regedent. It's on Facebook now as well. Thank you so much, Meizi, for this time together, for sharing all your insights and experience with xHyA. This was extremely insightful. I've seen a lot of very good comments. Thank you so much, and I wish you a good evening.
Thank you very much for inviting me, Alexander. All the best to everybody. Thank you.
Bye-bye.
Thank you very much. Bye-bye.